Hello everyone. Today's our topic is odontogenic keratocyst. This topic was selected by one of our viewers, and if you guys also have any topic in your mind or you want me to explain that topic, then please write it down on the comment section or DM me personally. So let's go to the topic directly. First, odontogenic keratocyst. So odontogenic keratocyst, if this is asked as in short note, so we will write first intro, then clinical feature, then radiographic feature, then histologic feature, and then treatment and prognosis. With histological feature, please try to draw an H&E diagram of OKC. Now let's start. Intro. Why this odontogenic keratocyst is named as keratocyst? Because the lining epithelium, it produces keratin and fills the cyst lumen. Okay, and it is in very aggressive odontogenic cyst. Now from where it is derived? It is derived from cell rest of dental lamina. सो ये 3 पॉइंट इंपॉर्टेंट हो गया. एक तो ये अग्रेसिव ओडोंटोजेनिक सिस्ट है, दूसरा इट प्रोड्यूसेस केराटिन एंड फिल्स द सिस्ट लुमेन, देयरफॉर इट इज टर्म्ड एज केराटोसिस्ट and it is derived from cell rest of dental lamina. Now let's go to the clinical features. The basics are here. Age. It can occur in any age, but it is mostly seen in second and third decade. It is more predominant in males and also predominant in mandible as compared to maxilla. Now, according to location, so according to location of the teeth, it is majority of the time it is seen with the third molar. Now, clinical manifestations. Okay, so patient may experience pain, soft tissue swelling, expansion of the bone. This is very important point. Expansion of the bone. Which bone? Cortical bone. Drainage and paresthesia of lip and teeth. Okay, now next, radiographic features. So this cyst can show unilocular radiolucency or multilocular radiolucency. See, here it is a unilocular radiolucency, whereas here it is multilocular radiolucency. Okay, so unilocular radiolucency is most common, mostly seen. And it has scalloping of border. It shows scalloping of border. Okay. Now, this scalloping of border represents the variation in growth pattern of the cyst. Okay. And in about 40% of the cases, this cyst is near the crown of the unerupted teeth. Therefore, this cyst occurs mostly with the third molar of the mandible. Impacted third molar of the mandible. Okay, so and in multilocular it is seen with the central cavity having satellite cyst. In next slides we will also study what is satellite cyst. Okay, but till now remember that multilocular radiolucency is seen with the central cavity having satellite cyst. Now this is especially located in the mandibular third molar area. Okay, especially in the mandibular third molar area में ये located होता है. This is a satellite cyst. See, these are the islands of epithelium in the connective tissue. Okay, now final diagnosis. How we do the final diagnosis whether it is OKC or not? By biopsy. And the most characteristic feature is buccal expansion is seen. Sometimes the proximity of the roots of the normal adjacent teeth can cause resorption of this root. Normal teeth है, उसके बगल में cyst है, so उस tooth के roots का resorption हो सकता है. So proximity to the root of normal adjacent teeth can cause resorption of these roots. This was radiological feature. See, this is unilocular cyst near third molar area. This is multilocular cyst. This is small satellite cyst in the connective tissue. Now histological features. In histological feature, first we will study that wall of OKZ is thin and there are some characteristics point. First of all, it has corrugated parakeratin layer. See, this is parakeratin layer. It is corrugated parakeratin layer. Then second point is it has lining epithelium of 6 to 10 cells in thickness. Lining epithelium of 6 to 10 cells in thickness. And third point, it has palisading basal cell layer with polarized nuclei. It has palisading basal cell layer with polarized nuclei, and this layer is also called as picket fence or tombstone appearance. This is the diagrammatic representation of basal cell layer. Sorry, the diagram is not good. And it has polarized nuclei. Now this epithelium is stratified squamous epithelium which is thin and have high mitotic activity. इसलिए तो 6 to 10 cells का thickness है ना. Now this epithelial cell produces keratin. So it produces orthokeratin in 10% of cases, parakeratin in 83%, and both type of keratin are seen in 7% cases. Now often this epithelium gets peeled off from the connective tissue. Okay, this is one more point, but these three are very important points. These are the characteristic features. Now this connective tissue can show the islands of epithelium called as satellite cyst or daughter cyst, which we studied here. See, islands of epithelium in the connective tissue, okay, called as satellite cyst or daughter cyst. Now the lumen is filled with straw colored fluid or thicker creamy material. And sometimes at the site of the inflammation we can see cholesterol or hyaline body present in the lumen. So normally this lumen contains straw colored fluid or thicker creamy material, but when there is an inflammation, then at the site of inflammation you can see cholesterol and hyaline body present in the lumen. Now treatment and prognosis. So if there is a neoplasm, okay, so when there is a neoplasm, then final treatment is surgical excision. But the complete eradication of the tumor, neoplasm is a tumor, so complete eradication of the tumor may be difficult. Why? Because wall is very thin. We studied before that wall is very thin. See, wall of OKC is very thin. Therefore, the complete eradication through surgical excision is very, very difficult. And this can lead to fragmentation of the OKC because wall is thin. And it can also, it is also difficult because there is perforation of the cortical bone. Okay, and it was a large part of the ramus. So the complication is too much for the total removal. Now recurrence. It has high recurrence. Okay, and it is more frequently recurrent in patient having cyst with basal cell, with nevoid basal cell carcinoma. So patient who have cyst with nevoid basal cell carcinoma have more recurrence rate as compared to patient with cyst without nevoid basal cell carcinoma. And it is more frequent in mandibular molar region, ramus region and ascending ramus region. And as compared to unilocular, it is more frequent in recurrence to multilocular. So multilocular में recurrence as compared to unilocular ज़्यादा होगा. Now what are the treatments? Treatment are marsupialization, enucleation and primary closure, enucleation and packing open. Okay, so I'm again repeating, if you have any other topic in your mind, please write it down in the comment section. I will make videos on it after completion of every chapter. Thank you.